Welcome to AETCM, the emergency medicine channel. Today we are discussing about a case of acute abdomen. Can we start the case?
Yes, sir. A 30-year-old male patient was brought to our ED with complaints of abdomen pain since the last 3 days. On initial 10-second assessment, patient is conscious, oriented and obeying to my commands. On primary survey, airway appears patent. There is no pooling or gurgling or other secretions. Sir. Breathing, his respiratory rate was 20 per minute with a saturation of 100% in room air. Bilateral air entry was equal, sir. Circulation, his heart rate was 108 per minute with a blood pressure of 130/90 millimeters of mercury and a CRT of less than 3 seconds. All peripheral pulses were felt equally and bilaterally, sir. Disability, his Glasgow Coma scale was E4, E5, M6 with pupil 2 millimeter reactive, sir. I asked for the pain score was 6, sir. Exposure wise, his temperature was...
What is the importance of pain score in this type of patients? You know that pain is there.
Depending on the pain, we should offer analgesics, pain-induced tachycardia and hypertension.
Can you tell what importance of pain score in emergency room? She has told, according to that pain score, we can give analgesia. This is one important thing. Then
reassessment after analgesia.
Reassessment is very important because your shift may finish by 8 o'clock. You will be seeing the patient at 7:30. You score the pain, okay, and after some other doctor will come. He has to assess some. There should be some mode of assessment. Only by this way you can assess the pain score. Okay, so pain is the 5th vital sign nowadays. Okay, so any patient who come with pain, whatever may be the reason, we have to control the pain first. Okay.
Exposure, his temperature was 100 degree Fahrenheit with a GR base of 135, sir. So at this point of time, he was having fever. So an IV cannula was secured, and even though he was having pain also, so first we gave injection paracetamol for it will cover for the fever and for the pain, sir. Then we thought of reassessing the pain after some time.
Where would you give IV paracetamol in emergency room? What are the definitive indication? Okay, this patient you should give IV paracetamol. We routinely use a lot of IV paracetamol. Definite indication.
For analgesic dose for pain, then febrile seizures and all. If in adults, if they are coming to control,
okay.
Then in case of
febrile seizure is not in adult.
Children.
Then pregnancy, in order to control, prevent
Fever
fetal tachycardia
in a pregnant lady. Okay.
Then in case of stroke and
one more MI. Okay. Any acute like ischemic injury like stroke and MI also you should give. Seizures, okay, especially in children. Then pregnancy. So the definite indications. But there are so many other conditions like pain. You can give the paracetamol. Okay.
Thyroid disease.
Yes, sir.
Hyperthyroidism, background hyperthyroidism. Maybe in arrhythmia, atrial fibrillation history. This will be little bit lesser indication, but definitely we routinely use lot of paracetamol. But these are the clear-cut indication for an IV paracetamol. So the pain score was 6 for this patient. Okay.
At this point, since he was complaining of abdomen pain also, we did a venous blood gas analysis.
Most important thing is you should know what type of pain it is. It's a colic pain or dragging pain, stabbing pain. That pain nature is very important. What is the type of pain here?
It was like a colic pain, sir.
Colic pain paracetamol will be helpful.
Ideally, we should prefer antispasmodic drugs and
should
opioids.
Be given associated with whatever paracetamol or whatever it is. You have to give an antispasmodic drug if you are strongly suspecting colicky pain. Okay.
What are the factors that you need to ask when somebody is coming with abdominal pain? What are the leading questions that you will ask?
Site of pain, nature of pain, radiation of pain, aggravating relieving factor, associated with vomiting, constipation is true.
Associated symptoms then?
Whether the pain is increasing after food intake or not.
That's association. So can you explain in these steps regarding this pain? Location?
Location. In this patient, location, he was complaining of pain which he initially felt it was around the umbilicus. Later on he felt it was on the first day, and it was associated with multiple episodes of non-bilious, non-projectile vomiting, and then he felt the pain is radiating to the right iliac fossa, sir. Pain was colicky in nature. There was no aggravating or relieving factors. He also complains of increased frequency of passing stools, but there was no loose stools. There was no blood or mucus in stool for this patient.
Okay.
Then associated dysuria was also. He's complaining of dysuria and increased frequency of maturation also.
Vomiting.
Vomiting was there. Vomiting was non-bilious, non-projectile vomiting, but not associated with food intake. Even whatever food he consumes, he will, irrespective of the food intake, he was complaining of vomiting.
Fever is there.
Fever history was not there, but when we assessed him, he was having fever.
Okay.
So you have got a young male who has come with an acute abdominal pain. Initially it used to start with around the umbilicus, now radiating to the right iliac fossa. So it's a classical history. What you are thinking for the first differential should be acute appendicitis. Continue.
Venous blood gas was taken, sir.
Why venous blood gas?
Usually just to look for the lactate, sir. In case of abdomen pain, in such cases like mesenteric ischemia, or there can be a elevated lactate.
Okay.
How many times you have seen lactate elevation in a blood gas for a mesenteric ischemia?
Actually, the lab lactate is more.
You have to send for a lab lactate because there are two isomers.
Yes, sir.
So usually what you are checking in the ABG will not be elevated. So you have to ask for a separate lab value. That is always better. And you want to look for lactate. So L and D isomers are there. So you have to look for that.
Sample history. There was no history of any allergies. Patient is not having any comorbidities, not on any regular medications. Last meal was 8 hours back. Patient complains of pain.
What is the importance of last meal in this patient?
If it is a surgical abdomen, surgical cause, sir, then we should be planning for emergency surgery. So last meal is important.
Even for intubation and surgical cases, it is very important. Okay.
Then nature of pain. Pain was started 3 days back, initially over the abdomen, then umbilicus radiating to the right iliac fossa, associated with multiple episodes of vomiting, non-bilious, non-projectile vomiting. And he was.
Do you have any differential diagnosis for this patient other than appendicitis? This is exactly the diagnosis, but you have any differential diagnosis?
He was also complaining of dysuria, sir. So can maybe a UTI or a renal calculi.
Simple UTI, renal calculi.
Renal calculi.
Okay.
Then in the right iliac fossa, typically there can be diverticulitis can be. And if it is a female, then we should suspect ruptured ectopic pregnancy.
Okay.
Rupture cyst.
Okay.
Ovarian torsion.
Okay. If the pain is for 1 or 2 weeks, what other differential diagnosis you can put for right lower abdominal pain? Fevers, low grade fever.
So was abscess.
Abscess is
Prostatitis.
Young male.
Some fever, vomiting.
Fever, vomiting, lower abdominal pain, right side.
2 weeks history.
2 weeks history of fever.
Intestinal TB.
Intestinal TB. Correct. Okay. Iliac area. Okay.
High grade fever. History of fever to start with. High grade fever. Travel history, everything is there. Anything else you can keep in mind?
Typhoid.
So on examination, sir, we assess the pain score again. He was telling a pain score of 4, sir.
Okay.
I offered analgesics. He wanted analgesics, so we gave tramadol, 50 milligram tramadol with emesit.
Okay.
Then examination, per abdomen examination, per abdomen wise on inspection, per abdomen scaphoid abdomen, there was no visible peristalsis, sir. On palpation there was tenderness over the right iliac fossa, and there was
position of tenderness.
McBurney's point, and that is McBurney's point is in the line joining the umbilicus and the anterior superior iliac spine in the medial 1/3 and lateral 2/3, sir. So he was having rebound tenderness over the McBurney's point. Lateral 1/3. So having tenderness over that. Then bubble sounds were.
So when you are palpating the abdomen, it's a very basic question. How do you palpate abdomen in a case who is having right inguinal pain?
Palpate from the normal area first, then come to the
Come
painful
to-
area.
Wherever there is no pain, palpate
Pain.
first. The most painful area should be palpated very last palpation. That should be kept in mind. Okay.
What are the other bedside tests that you can do to confirm that it is an appendicitis? Any other test?
There are other tests, sir. In appendicitis, there can be peritoneal inflammation. So, other tests are there. Because of peritoneal inflammation, when we press on the left iliac fossa, there can be pain in the right iliac fossa. That is called as Rosen sign. Then, in case of retrocecal appendix and all, there can be inflammation in the psoas muscle. So, when we ask the patient to extend the hip, there can be pain over the right iliac fossa. That is called psoas sign. And an obturator sign is also there. That is also because of peritoneal inflammation. If we ask the patient to flex the hip and ask to internal or external rotate the hip, then he will be having pain over the right iliac fossa. Then in the bedside, we will assess the Mandrit's score. That means Alvarado scoring system. If the score is more than 8, then we can conclude it as an appendix. Most probably appendicitis.
Maybe Alvarado score is that what we learned from MBBS day onwards. But the most important one thing that you need to pick up is the right iliac fossa tenderness. McBurney's point tenderness is the most specific for appendicitis, and its sensitivity is very good as a full Alvarado score. If you are not able to do a full Alvarado score, you can just do the right iliac fossa pain. Almost the sensitivity and specificity is good for acute appendicitis. You need to do a PR for this patient, ideally, for rectal examination. See, whenever we have a better clinical tools like ultrasound now easily available, whenever it was previously not available, when you have a retrocecal appendix, you can easily do a PR examination and look for tenderness. That was being done clinically before. But when the patient is already suffering from pain right now, to do a PR examination is not warranted unless and until you are suspecting something else as a differential diagnosis. Unless and until actually PR is not rightly needed, we can get a bedside ultrasound and you can easily look for the inflammation of appendix. Okay.
So this patient, our main differential diagnosis was acute appendicitis, or it can be a simple UTI, but most probably
Not simple UTI, renal stone.
male
Stone.
stone.
Renal stone. Okay. Simple UTI will never present like this. McBurney's point tenderness, right lower angle. That is not very common. They will have dysuria, hematuria, all these things. Okay.
What could be the reason for dysuria for this patient? You are thinking in terms of appendicitis. Why he should have a dysuria?
Dehydration secondary to abdomen pain.
Okay.
Vomiting, he is not taking enough fluids. So all those
Concentrated
things.
urine. In many patients who is having abdomen, acute abdomen pain, they have spasm in the urinary tract also. Okay. Both have similar nerve innervation, so they can have spasm there also. Okay.
So we checked the Alvarado score, sir. Alvarado score was coming around 8. It means first we will be checking the pains, M for migrating pain. Then we will be, so we will give a score of 1. Then if the patient is having anorexia, we will give a score of 1. Then if there is associated nausea, we will be giving a score of 1. Then if there is tenderness, we will be giving a score of 2. Then if there is rebound tenderness, we will be giving a score of 1. Then elevated leukocytes, depending on the lab values. If there is elevated leukocyte neutrophilic predominance, then we will be giving a score of 1. And temperature, if there is fever, we will be giving a score of 2, sir. So we asked for a bedside ultrasound, sir. Ultrasound was showing a appendix more than 6 millimeter diameter with reduced bowel movements and thick and inflamed appendix with inflammation around the appendix, sir. So it was USG was confirmatory about appendicitis, and when the blood reports came, his total count was 16,000 with the neutrophils of 87%. And CRP was 239, sir. So acute appendicitis with inflammation, sir.
What are the other ultrasound features in appendicitis?
In appendix, aperistaltic blind loop we can see, sir. Then free fluid in right iliac fossa we can see. Then probe tenderness will be one another finding.
Target same. Maybe the appendix same.
Okay.
Then Doppler findings. Also.
Doppler findings. Associated Doppler, you can look for necrosis and everything. So, you need any other evaluation for this, for a confirmatory diagnosis?
If at all appendix is not visible and if we are suspecting another pathology, then we will go for a CCT abdomen, sir.
Okay.
Contrast or non-contrast?
IV or oral contrast.
Contrast is better because other differential diagnosis, one is stone that you does not require contrast. But if you are thinking about ileocecal tuberculosis and all, you mostly require a contrast CT.
What are the other medical conditions that you can think of? Somebody is coming with acute abdomen, not this patient. Somebody is coming to the emergency room with acute abdomen. You're doing an ultrasound is negative. You're doing a CT, everything is negative. What are the differential that you can think?
DKA, lead poisoning, acute intermittent porphyria,
Okay.
Inferior oral MI.
right lobe zone pneumonia.
Right lower zone.
Pancreatitis.
Pancreatitis. It's a surgical.
Surgical.
Surgical. That's
Ischemia, mesenteric.
Okay.
okay.
Then other surgical causes can be perforation, mesenteric ischemia, bowel obstruction, or cecal volvulus. Then gynecological causes are also there.
It's in a female patient.
This is a male. Male.
Gynecological causes should be suspected in any
Female.
female patient who is in childbearing age group. What should be the first suspicion?
Urinary, first a UPT should be done and ectopic pregnancy
Should be ruled out. Any case who come with lower abdomen pain, especially a young female or a childbearing age, do a urine pregnancy test. Then evaluate with consent. Okay, that is very important.
So what was done further for this patient?
This patient.
What we should do from emergency room? What?
First, we should keep a patient NPO.
Okay.
Then we should start on IV fluids. We should give a necessary pain management and antiemetics. Then we should ask for a surgical opinion. Then antibiotics also should be started.
What antibiotic you want to give?
Usually, we should prefer cephalosporin, third
Third
generation
generation.
cephalosporin, ciprofloxacin or ciprofloxacin with metronidazole.
Okay. For
Surgery.
pain,
Surgery.
what you can give? Pain management.
Pain management, most preferred pain management is opioid analgesics, sir. They will, advantage is that it will reduce pain and it is also having mild antiperistaltic activity. So the pain because of the peristalsis also will not be there, sir.
Want to give NSAIDs?
NSAID to reduce inflammation, we can prefer NSAID.
Here you are already given paracetamol that has got an anti-inflammatory action. But if you have more pain, NSAIDs like diclofenac or anything can be used. Okay, unless you are not thinking about perforation. Okay.
Then surgery wise, usually appendicitis is having some sort of inflammation. So delayed surgery is preferred after giving antibiotic therapy. If the patient is after making the gut sterilized, then we should plan for a
To
surgery.
first is reduce the inflammation so that the injury to the bowel can be reduced. Previously it was acute appendicitis, emergency surgery. Nowadays you can postpone the surgery for an elective time. Okay. What are the indications for emergency surgery in appendicitis?
Ruptured appendix, sir, gangrenous appendix.
Then?
Abscess.
Appendicular abscess,
That is the
usually
most
pigtail.
important thing what we are seeing is abscess.
In case of abscess, they will usually prefer a pigtail drainage
Removal
of
of
the abscess
pus.
and internal appendicectomy after giving antibiotics for 6
Okay.
weeks.
What happened to this patient?
This patient was started on antibiotics and then he was taken for surgery, sir.
Pain is another indication for many surgeons. Suppose the patient's pain is not getting relieved even after your conservative treatment. Even the book says delayed surgery is okay. But patient pain is another indication. They take it as an indication and do surgery. Okay.
Fine, sir.
Anything else you want to ask? Nothing. Okay, thank you.